and welcome back to my channel, Cypress Wellness Collective. My name's Erica Bent. I'm a licensed therapist and eating disorder specialist. In today's video, we're going to talk about the transition to phase 2 of family-based treatment, or FBT. Today's video is going to talk about the requirements or expectations that we want to meet before we transition to phase 2. In our next video, we're going to talk about how to do that transition. And if you're not familiar with what family-based treatment is at this point, then head on over to our initial videos to get a better sense of what this treatment looks like. Let's dive in. So first, we're going to talk about the requirements of transitioning from phase 1 to phase 2. But phase 2 is essentially autonomy. When we move from parents or caregivers being in charge of the meal plan, of meal planning and preparation, of supporting at all meals and snacks, of creating a lot of structure in the home environment, to allowing your teen to have more autonomy and more agency, and essentially moving back to normal life. So, for example, having lunch on their own at school again, or having choice in the kitchen about what they want to have for snack, or just not having any kind of supervision at all. It's a gradual process that starts by increasing a little bit of choice and agency and autonomy, and as things go well, that increases over time. But first and foremost, let's talk about what we want to experience and what are the expectations before we move into increasing some of that agency and autonomy. First and foremost, we want to take a look at medical stability. And medical stability captures weight recovery, but it also captures vital sign stability, lab work, looking at hormones, bone health, so on and so forth. Anything else that might be going on for your child. When weight is a factor, let's say someone is underweight, as in the case of anorexia or ARFID or other types of eating disorders, we want to ensure that their weight is stable. And this is really important in ARFID and anorexia because an undernourished brain is often not a healthy brain and not able to make choice from that healthy place if they're undernourished. And so we want to see someone at their target goal weight before we transition to autonomy. So ideally, they're at 100% of that target goal weight. Now, in some cases, we can move towards autonomy before reaching 100% of that target goal weight. I would say at a minimum, we're at 90%, and ideally, we're further along than that. The vast majority of teens are not ready for autonomy when they're under their target goal weight. And you also want to think about the meal plan. So if someone is under where they need to be weight-wise, then their meal plan is going to be significantly higher than if they're not needing to gain weight. And a high meal plan is a difficult meal plan. And so that's just another factor to consider before transitioning over if we're not meeting those goals yet. They need to be able to eat enough to continue improving medically. We don't want anything to thwart those goals of reaching medical stability, again, because an undernourished brain is often not going to be a brain that is able to recover psychologically. So it's a precursor to psychological recovery. And other medical goals should really be resolved within reason. So we would expect to see vital sign stability. We want to see improvement in lab work. We don't want to see anything that could be fatal or dangerous in any way, right? We don't want to put the seriousness of health in your teen's hands when they're not ready for it. Now, there's other health markers that are going to be a much longer road to recovery, so we're not going to focus on everything. And an example of that might be bone density. If someone's experienced a loss in bone density, that can take some time to resolve. So talk to your care team and make the best decision for you. We also want to see improvements in behavior. Now, this kind of goes without saying, right? If your teen is struggling with meeting their meal plan, or they're continuing to engage in excessive exercise, or they're continuing to hide food or throw away food, then it's a clear indication they're not ready for autonomy. But perhaps you've seen a significant reduction in eating disorder behaviors, but you haven't seen a complete reduction in eating disorder behaviors. It's nuanced. That's okay. We may give autonomy and agency in the areas in which we feel like your teen is able to tolerate it and not engage in eating disorder behaviors. But in another area, they might still really need your support. So, an example of this might be your teen does really well at breakfast because there's the least amount of distress. And so we may be able to give them some agency in choosing what they want to have for breakfast, or even having a sleepover where they're having breakfast with a friend and you're not with them. But over time, as the day goes on, their distress increases. They feel more full in their stomach. Stress from the day adds up, so their evening snack is the hardest one to get through. So you may not have them do evening snack over at the friend's house. They may not be ready for that. You need to still support them. So that we can choose, but ultimately we want to make sure that we're not providing autonomy where the eating disorder is going to capitalize on it. And we expect that teens will struggle with eating disorder thoughts and urges, but we want to make sure that they're practicing externalization. They're able to externalize their eating disorder thoughts and urges and behaviors enough, and they have a strong enough healthy self to be able to recognize that and challenge those thoughts and urges, or at least not engage in them. You want to be able to trust that your teen is in the driver's seat of their decisions and they're able to tolerate distress and regulate their emotions when they're overwhelmed. So they're actively drawing on healthier coping skills to regulate stress. You also want to ensure that they are able to listen to their healthy self, meaning the healthy part of their mind that's rooted in sound judgment and stable emotions. They're able to externalize that eating disorder part of themselves and access a healthier, intuitive, wise part of themselves that's going to make sound decisions. And you also want to ensure that they're eating all the food provided to them in a reasonable amount of time without too much fear or too much resistance. They, again, need to be able to challenge their eating disorder behaviors. Your teen is able to tackle food challenges and rigidity around food decreases. So there's an understanding that exposure to fear and guilt is a necessary and an important part of recovery, and your teen is willing to cooperate with you around these challenges. So over time, we're seeing more collaboration around fear food exposures. We're seeing increased completion of challenges, and this is just improving over time. And ideally, we're seeing some extinction of fear. So those challenges get a little easier over time. And your teen has some intrinsic motivation for recovery. Now, in family-based treatment, we don't expect teens to have a motivation for recovery, at least not to start. But once we start increasing autonomy, there should be some development of this intrinsic motivation. Ideally, motivation to recover, but at the very least, motivation to remain healthy, to keep doing what they need to do to be healthy, and to keep working on their recovery. So let's talk a little bit about motivation. To understand motivation and how that shifts, we have to understand how it shows up in an eating disorder. And in anorexia and in many of the other eating disorders, they're egosyntonic. And egosyntonic refers to instincts or ideas that are acceptable to the self, are also the same as what we see in the illness. So the illness's values are compatible with the person's values or the person's way of thinking. They're consistent with one's fundamental personality and belief system, which is why we don't see a desire to recover, because they're aligned, right? They're coming from the same place. And so we start to externalize the eating disorder, and that also means externalizing those values systems. And over time, we want to see some motivation and recovery by evaluating those value systems and seeing where they may actually be incompatible. So let's say you have a teen who is an athlete, and initially they engaged in their eating disorder because it seemed like it improved their performance. And then over time, we start to realize that actually eating disorder behaviors impact the body in negative ways, and they don't actually improve performance, even if it may feel that way. So that's a good example of a kind of an easier example of when we are able to challenge some of those values. So over time, the expectation is that through externalization and processing some of these things, teens can separate themselves from their eating disorder and start to realize where those values are in conflict. And over time, motivation can develop. Now, motivation almost always starts external. An example is, I don't want to have to go to so many medical appointments, or I don't want to have to be supervised anymore. Parents are often the drivers of motivation early on, and that's through behavior modification, and it's through creating expectation and structure around the eating disorder recovery. So parents will create expectation around being able to stop engaging in behaviors or being able to regulate emotions in order to be able to have the life that they want to have. So we have to leverage motivation through these external factors. So an example is, I really want you to be able to enjoy sleepovers at your friend's house this weekend. So let's make sure we have a plan in place so your eating disorder can't take that away from you. So an example, maybe the friend's parent is supervising the meal, or maybe you have your teen FaceTime you during the meal, or perhaps they're able to take a photo and send it to you. Whatever the structure looks like, you're setting the expectation that nothing is going to get in the way of your recovery. And so as we're increasing autonomy, you have to be willing to work with us on this. So there is some kind of supervision or exchange that happens so we can ensure that your eating disorder doesn't take advantage of the situation and inhibit you from living the life you want to live. Now, eventually, motivation does become more intrinsic and internal, and it may sound like I want to be able to be healthy again so I can play sports, or I want to have less anxiety and distress around eating and my body. Your teen expresses some readiness to take on more responsibility. So this is important. We're not going to move to increased autonomy if your teen is saying they're not ready for it. Now, many teens express a desire to regain control over their eating long before they're actually ready. And this premature push for independence may be partially motivated by a normal adolescent drive for freedom, but it may also be motivated by the eating disorder's desire to restrict and lose weight. So we really have to take a look at readiness. And it's a mistake to only base the decision around autonomy on your teen's expressed desire for readiness. Rather, everything we just talked about, all of the former criteria, they have to be met in addition to your teen saying they are ready. Now let's talk a little bit about relapse prevention. So research has shown that higher rates of relapse happen when autonomy is transferred over prematurely and your teen is not quite ready to handle it. And it often leads to an increase in eating disorder thoughts, urges, and behaviors. I like to say that when we decrease structure and increase autonomy, we should automatically assume that there's going to be an increase in eating disorder thoughts and urges. And we want to prepare teens for that. And it kind of makes sense. Like when you don't have the option to engage in a behavior, then it's not even on your mind. But the moment the option presents itself, there's an opportunity. It's like that thought just automatically pops up. And that's because of neuroplasticity and how our mind works, right? And we haven't maybe created that strong neural pathway change quite yet. But that's okay. It's okay that teens have thoughts and urges and they pop up as we decrease structure and increase autonomy. We want to prepare them for that, and we want to help them be able to handle it in a way where they're not engaging in the behavior and they have adequate coping tools to respond differently. Now, we know that if a teen does regress or they do relapse, that it's often coupled with a much harder time to get back to where they were pre-relapse. And so it's just really hard to come back from it. So in FBT, what I like to say is we want to do it right the first time, and we want to prevent any kind of relapse, because coming back from that is going to be much harder. So it's always better to be more conservative, to go slower, and to be over-prepared than go too quickly and be under-prepared, leading to a regression or a relapse. Next up, we'll talk a little bit about how to transition to phase 2 FBT, so stay tuned for our next video. And if you're interested in following us in our other platforms, check out our website. You can join our email mailing list or find us on social media at Cypress Wellness Collective. Thanks, and see you next time.